Thank you, everybody, for joining us in part three of the Head and Neck Cancers Program 2022 CME series. This is a service of Yale New Haven Health Smilow Cancer Hospital and the Yale Cancer Center. And it's really been a very productive and interesting last few seminars. We've talked a lot about pushing the bounds of surgical treatment of head and neck cancer in our first program, and then talking about the latest in clinical trials and immunotherapy and de-intensification of treatment in our second series. And now we are very excited to talk about the future of head and neck cancer treatment today. And I'll have Dr. Burtness take it from here, and she'll be introducing our speakers. So thank you, everybody.
Hi, welcome everybody. We're really delighted that you've joined us, and I'm really delighted to have the opportunity to introduce my close partner, collaborator, friend, Dr. Aarti Bhatia, who's an associate professor of medical oncology here at Yale School of Medicine and Smilow, and a very, very busy clinical investigator and clinician in the area of developmental therapeutics for head and neck cancer. So Dr. Bhatia went to medical school in India, has an MPH from the University of Texas, did her residency at Johns Hopkins Sinai, and her fellowship in medical oncology at Temple University Fox Chase Cancer Center. Her first faculty position was here at Yale, and she has built up an extensive referral network in the region for head and neck cancer, and chairs a number of studies, including a phase 3 study in the NCTN, which will be accrued to nationally. So she's going to be speaking to us about immunotherapy and anti-angiogenics as an approach for metastatic recurrent head and neck cancer.
Thank you, Barbara. I'm just going to share my slides. Okay. Good evening, everyone, and thank you for the opportunity to present here today. I will be reviewing, that's my first slide. Okay, I'll be reviewing the immunotherapy landscape and recent data in patients with head and neck cancers. I'm going to mainly focus on, the role of immunotherapy so far in recurrent metastatic disease, and then some trials that we're excited about and we're opening at Yale. But if time permits, I might go briefly into locally advanced disease as well. So Keynote-12 was really the first report for the efficacy and safety of an anti-PD-1 drug in patients with PD-L1 positive recurrent metastatic head and neck cancers. 104 patients, majority of whom were heavily pretreated, were screened, and consistent with other studies, about 80% had PD-L1 positive tumors. 60 of these patients were treated with pembrolizumab every 3 weeks. The primary endpoint was overall response rate. This is the waterfall plot showing patient responses to treatment. The overall response was about 18% higher for HPV positive patients, about 25%, and 14% in HPV negative patients. The median progression-free survival was about 2 months for the entire cohort and 14 months for the responders. And median overall survival was 13 months for the entire cohort. Subsequently, Checkmate 141, which was published a few months later, was a randomized phase 3 study that enrolled about 361 platinum refractory patients with head and neck cancers who were then randomized to, in a 2:1 fashion, to either nivolumab every 2 weeks or investigator's choice standard of care systemic therapy. The primary endpoint was overall survival, and those are shown here. Overall survival was significantly longer for nivolumab, so it was about 7.5 months versus 5.1 months with the standard systemic therapy. And median progression-free survival, similar to the Keynote study, was about 2 months for the entire cohort. Again, kind of demonstrating the ability of immune checkpoint therapy to change the overall biology of the disease and prognosis for patients, even if it didn't significantly impact clinical responses. Subsequently, Keynote Keynote-040 was a randomized phase 3 study that examined the role of pembrolizumab in about 250 platinum refractory patients with head and neck cancers. And patients were randomized 1:1 to either pembro versus investigator's choice standard of care systemic therapy. Patients were stratified by PD-L1 status, and the primary endpoint was overall survival. And pembro significantly improved survival over standard of care treatments and was better tolerated. Recently, the 6-year data was presented at ESMO this year and showed that the survival benefit was maintained in the intent to treat population, in the CPS greater than equal to 1 population, as well as in the TPS over 50 cohort. And PD-L1 staining intensity correlated with the degree of survival benefit. Progression-free survival was not significantly prolonged for the entire cohort or for the TPS over 1 population, but did improve for the TPS over 50 population. And overall response rates were improved with pembro versus standard of care, with greater complete responses being seen. Importantly, the duration of response was significantly improved with pembro, and we see this now famous tail to the survival curve of a small but real number of long-term responders. The duration of response and overall response rate were also prolonged for CPS greater than 1 and the TPS over 50 population. And pembro again demonstrated better tolerability, fewer high-grade adverse events than systemic chemotherapies. So to conclude from the 6-year follow-up, pembro continued to show survival benefit when compared with standard of care, systemic chemotherapy, or cetuximab in recurrent and metastatic head and neck cancer patients across all PD-L1 subgroups. Increased benefit was seen with increasing PD-L1 expression. More durable responses were seen with pembro. There were no new safety signals with longer-term follow-up, and results from this study continued to support the use of pembro in the second-line treatment of head and neck cancers. Keynote-048 was the pivotal study that Yale led and examined the role of pembrolizumab in the first-line setting and pitted it against the then standard of care, which was the extreme regimen. This was a randomized phase 3 trial in previously untreated patients, so first-line recurrent metastatic head and neck cancer that were randomized evenly to pembro alone or pembrolizumab plus chemotherapy. The chemotherapy backbone was platinum and 5-FU, or cetuximab plus chemotherapy, which was the extreme regimen. And patients were stratified by PD-L1 status, which was measured as a combined positive score of tumor and immune cell staining. The primary endpoints were overall survival and progression-free survival. Almost 900 patients were randomized. Of these, 85% had a CPS of 1 or greater, and 40% had CPS of 20 or greater. And pembro alone improved survival versus extreme in the CPS 20 greater and CPS 1 and greater population. It was non-inferior for the total population. Pembro plus chemo improved survival versus extreme in the total population, as well as in the CPS greater than 1 or CPS greater than 20 cohorts. And 5-year follow-up from this study was presented at ESMO this year too. In the intent to treat population, both pembro and pembro plus chemo improved survival versus extreme. The survival benefit was greater in the CPS greater than 1 cohort and even better in the CPS greater than 20 cohort. So again, staining intensity correlated with overall survival. And consistent with previous data, it did not improve progression-free survival in the intent to treat population, but pembro plus chemo was non-inferior to in progression-free survival versus extreme. Both pembro and pembro plus chemo were non-inferior to extreme for the CPS greater than 1 cohort, as well as for the CPS greater than 20 cohort. And although pembro had lower response rates than extreme, the combination of pembro plus chemo had response rates that were similar to extreme, about 36-37%. The duration of responses were significantly prolonged with immunotherapy. Both response rates and duration of response correlated with the degree of intensity of PD-L1 staining, with higher CPS scores associated with a greater clinical benefit. And as before, omitting chemotherapy made the treatment more tolerable, with pembro alone having the lowest rate of high-grade adverse events. So to conclude with the 5-year follow-up, the first-line pembrolizumab monotherapy group, as well as pembro plus chemo group, continue to show clinical benefit in recurrent and metastatic disease, regardless of PD-L1 status. Duration of responses were extended in both the immunotherapy arms, and there were no new safety concerns, again supporting the use of first-line immunotherapy. So because benefit correlates with PD-L1 staining, PD-L1 expression is required for gaining approval for pembrolizumab monotherapy in the United States, while PD-L1 negative or unknown patients are typically more commonly treated with combination pembrolizumab and chemotherapy. The big question is how to time immunotherapy, given that we have both approval in first-line and second-line settings. So treatment beyond progression on KEYNOTE-048 treatment arms and progression-free survival on second-line treatments was recorded, and the data was presented at ASCO a couple years ago. The pembrolizumab-containing arms had significantly improved progression-free survival on second-line treatments compared to those that got extreme in the first line, and that lent support to using immunotherapy in the frontline setting. All the trials we've discussed thus far led to the FDA approval initially of nivolumab and pembrolizumab in platinum refractory head and neck cancer patients, so in the second line setting. And in 2019, based on KEYNOTE-048, we got approval for pembrolizumab monotherapy in PD-L1 positive patients in the first line setting, and to pembro plus chemo across all patient cohorts. Other trials have examined the addition of CTLA-4 inhibition to anti-PD-L1 or anti-PD-1 therapy to see if response rates can be improved, if there can be a further increase in survival benefit. All these studies have been negative. There has maybe been some signal of benefit seen in the PD-L1 high cohorts, but combination immune checkpoint inhibition is really currently only being given in the context of a clinical trial. And apart from combining anti-PD-1 and anti-CTLA-4 therapy, other strategies are being looked at in clinical trials to overcome resistance to anti-PD-1 inhibition. Preclinical and clinical studies have shown that antibody blockade of semaphore and 4D, which is the SEMA4D protein, promotes tumor infiltration and activation of dendritic cells and CD8 positive T cells, and reverses immunosuppression in the tumor microenvironment. Pepinimab is a SEMA4D blocking antibody, which is being examined in combination with pembrolizumab in head and neck cancer in a trial that we're accruing to right now. The combination of pepinimab and avelumab in non-small cell lung cancer did show some clinical benefit, including in patients with PD-L1 low disease and those who were immune checkpoint inhibition resistant. There was preliminary data reported at ASCO this year in 3 patients with head and neck cancer, recurrent metastatic disease, and 2 of these 3 patients with PD-L1 low tumors had a complete response to treatment. So we're pretty excited about this option for our patients. The trial will be opening end of this week at Yale, and we would love to put patients on. Head and neck cancer patients are also frequently hypoxic and show elevated VEGF signaling, which is associated with immunosuppression again in the tumor microenvironment. There is known to be an impact on, guess I'm not moving enough. There's shown to be impact on myeloid-derived suppressor cells, regulatory use recruitment of cytotoxic effectors like CD8 T cells and natural killer cells. And multiple randomized studies in different disease sites in lung, renal, liver, endometrial have shown the clinical benefit of combining anti-PD-L1 treatment, atezolizumab, with the VEGF inhibitor bevacizumab. In head and neck cancers, in recurrent metastatic disease, there was a phase 1 trial which examined the role of pembrolizumab and lenvatinib. Lenvatinib is an oral tyrosine kinase inhibitor of VEGF, and 22 patients with recurrent metastatic disease were treated with a combination. Majority of these patients had tumor size reduction, and objective responses were seen in 36% of patients with a progression-free survival of 8.2 months. So we postulated that VEGF blockade with bevacizumab will reverse these immunosuppressive resistance mechanisms in the microenvironment and lead to improved anti-tumor immunity and clinical responses in a subset of patients who were previously treated with immune checkpoint blockade. We therefore designed this phase 2 and 3 multi-arm randomized study, which was recently activated through ECOG and is also opening at Yale in the next week or two, also in the care centers at Yale. And patients with recurrent metastatic disease who have progressed on anti-PD-1 therapy in the first line will be randomized to one of 3 treatment arms, platinum doublet plus chemo plus cetuximab, which will serve as control, platinum doublet plus bevacizumab, and atezolizumab plus bevacizumab. And winner of the 2 experimental arms in phase 2 will advance to phase 3 against the control. This is again a second-line treatment trial. So the first line was the Vaccines study we talked about. This is second line, and we're very excited to be putting patients onto these trials. I'm not sure if I have some time to talk about immunotherapy in locally advanced disease, but I can be brief. The Javelin.
Yeah, no, go ahead.
Okay, so the Javelin study was actually the first to explore the addition of anti-PD-L1 therapy, so avelumab in combination with cisplatin and radiation versus placebo plus cisplatin radiation in patients with locally advanced disease. It was a phase 3 blinded study. 700 patients were enrolled. The primary endpoint was progression-free survival. And as you can see from the forest plot here, not only did avelumab not improve progression-free and overall survival, it actually appeared to somewhat worsen the outcomes, although it wasn't statistically significant. The difference in survival started to emerge later in the disease course, so about a year after randomization, making it more likely because of disease than actually because of drug. But essentially, it was a negative study. And at ESMO this year, we also saw results from Keynote 412. This was the 1:1 randomization between pembrolizumab with chemoradiation versus placebo with chemoradiation. The pembro was continued through the chemoradiation and also as maintenance for 14 total cycles. The primary endpoint was event-free survival, and this was the first phase 3 trial using a PD-1 inhibitor. Javelin used a PD-L1 inhibitor in combination with chemoradiation. The baseline patient characteristics were pretty well matched between the 2 treatment arms, including for PD-L1 scores as well as for HPV positive status. Treatment compliance was actually pretty good. Over 90% of patients on both arms completed definitive chemoradiation, and about 90% of patients on both arms also got our critical threshold of over 200 milligrams per meter square of the cisplatin. There was a slight benefit for the use of pembro. The hazard ratio was 0.83, but it crossed the confidence interval of 1. The p-value although it was 0.04, did not meet the superiority threshold, which had been set at 0.02 for this study. And a similar, a similar proportion of patients had local versus distant progression on both arms. The forest plot is a little bit different here as compared to the Javelin study that we just saw. Many of the subgroups here seem to be deriving like a hint of clinical benefit, although it wasn't statistically significant. And higher PD-L1 positive patients seem to benefit more than the lower CPS scores. Looking at overall survival, the median had not been reached in either arm. The hazard ratio was 0.9, but again, the confidence interval crossed 1. There was a pre-specified analysis in this trial for CPS 1 or greater patients, and here the spread between the curves was a little bit better, but still not statistically significant. And there was also a post-hoc analysis in the CPS over 20 group. There was a smaller number of patients to be analyzed here, about 146 in each arm. The event-free survival hazard ratio was 0.73. At 3 years, the event-free survival was 57.2% for the control versus 67% for the experimental group. Overall survival did seem to also improve a little bit with the experimental group. The hazard ratio was 0.67, but again, the confidence interval did cross 1. So just maybe, I'm not sure if, there would have been a different outcome if greater number of PD-L1 high score patients had been enrolled on the study. In terms of toxicity, there were any grade adverse events were 100% and 99% between the two arms, but these patients were getting 7 weeks of chemoradiation, which is a known very toxic treatment. And the conclusion from this study was that for patients with PD-L1 expression, there was a modest benefit that did not meet statistical significance on event-free survival and overall survival. To summarize, basically the take-home points from today's talk, anti-PD-1 therapy has undoubtedly changed the treatment landscape for recurrent and metastatic head and neck cancer patients. There has been a significant improvement in overall survival, leading to first-line approval for this drug. CTLA-4 inhibition in combination with anti-PD-1 therapy did not show any improvement in outcomes, although there may be some benefit in patients with PD-L1 high or otherwise inflamed tumors. Future trials are, of course, focusing on novel protein antibodies that could combine well with immune checkpoint inhibition. We have 2 such trials we are opening here now. And most certainly, the future generation of trials is looking promising. So that's all I have. Thank you for your attention. I'm happy to take any questions.
And just as a reminder, please put your questions either in the chat or the Q&A. Maybe I'll just start. Very striking that on the one hand, there's a strong signal for PD-1 inhibition in the recurrent metastatic setting. You clearly see a little bit of an effect with the PD-1 inhibitor in the chemo RT setting, and yet if you tallied up all the immunotherapy trials in head and neck cancer, maybe we have more negative trials than positive trials. I saw the other day that a company's beginning phase 1 therapy, and maybe this is a thing that Dr. Hafez, who's going to be one of our future speakers, might want to jump in on as well. But they're looking at dual PD-L1, PD-L2 targeting. And, given that PD-L2 expression may be a little bit higher in head and neck cancers than in others, do you think that could be one reason the PD-L1 drugs haven't had as much success? And, is that something that maybe we should be thinking about as a biomarker?
Yeah, most of the negative trials have been the anti-PD-L1 drugs. Of course, it would be useful to build that into prospective trials as a validating biomarker. It would be interesting to see what a PD-L1, PD-L2 inhibitor might do in addition to the drugs we've seen so far.
So we haven't introduced Dr. Hafez yet, and we'll do that later. But are there PD-L2 drugs that you've worked with in the phase 1 team yet, or do you have an idea?
So yeah, unfortunately, I'm very interested, and I think head and neck is a great place to investigate. But we have not had any in our portfolio, and we don't have any in the pipeline at the moment. But it is an area of that is in active development right now.
Aarti, I have a question as well. I'm more of a clinical. Ben presented some great clinical trials and clinical trial results. So when you see a patient with recurrent or metastatic head and neck cancer in your clinic, what do you tell them is the likelihood of response, say at 5 years, that they're going to be alive? And is it different for recurrent versus metastatic? And how does it differ based on the CPS score of less than 1 versus greater than 1?
So it's really, it's not a big proportion of patients that actually have long-term 5-year cure rates. Would be wrong to kind of offer that hope to patients in general. I usually don't start off with numbers. That's not something patients are looking for when we're seeing them in clinic. And almost nobody ever, pointedly asks me what my prognosis is going to be at 5 years. But I will tell them, it's not curable, of course, but it's treatable. We have some excellent drugs, some new drugs. We do see some durable long-term responses in some patients. And many people know about immunotherapy already, so they actually come asking and looking for the treatment. But yeah, I'm not necessarily giving numbers in terms of, because if you see the tail, it's really a very small tail. It's not the vast majority of patients.
Great. And does it vary? Does their response, even short-term response, vary based on whether it's recurrent disease versus metastatic disease? And then how about on the...
So it depends if it's in a prior radiation field. I think in general with recurrent disease that's in a prior radiation field, we tend to see more treatment resistance to immunotherapy versus a radiation naive patient. And CPS scores, of course, matter. So, you know, the higher CPS scores, we do tend to sometimes see better responses than in the PD-L1 negative or 0 patients. Those are not the patients we're trying to put on pembro monotherapy.
Thank you.
Thank you for that wonderful review. I'm happy now to be turning to our next speaker, Dr. Jeffrey Ishizuka. He graduated from Williams College and then was a Rhodes Scholar in immunology at Oxford and the NIH. He had his clinical training at Harvard, MIT, and Brigham and Women's Hospital, and did his medical oncology fellowship at the Dana-Farber. He was recruited to Yale as an assistant professor of medicine and holds a secondary appointment in the Department of Immunobiology and Pathology. He's actively leading a lab that studies inflammation and cancer immunology, and has funding from the V Foundation and NIH to study the immune microenvironment in head and neck cancer. And he's going to be speaking to us about some of this work, particularly in the context of hypoxia, which is such an important characteristic of head and neck cancer.
Thanks so much. Let me just get my slides loaded here. And do those look okay? Great. It's great to follow Dr. Bhatia as well in terms of she did a wonderful job of kind of introducing state of the art for immunotherapy and also talking a little bit about angiogenesis as well. And so that'll make things actually go a little bit faster. As Barbara mentioned, I'll be speaking tonight about hypoxia and innate immune signaling in head and neck cancers. And really, I want to go through about 4 things. The first is just to make the argument with evidence that hypoxia matters in cancer broadly, but specifically in head and neck tumors. And then to ask the question as to how head and neck cancers activate hypoxia signaling. And then, we'll follow that up by making an argument that hypoxia signaling and innate immunity interact in potentially important ways. And finally, kind of unpack therapeutic consequences for how we should target this pathway. To start, though, this is a study that was published a couple years ago where they just looked at hypoxia signaling across different tumor types. And there are a couple of features that I think are worth pointing out. They used a gene signature for hypoxia activation, and they show different tumor types across the bottom, all different types of solid tumors. I think the 2 things I take away from this are, number 1, that hypoxia is pretty common across tumor types. But number 2, that if you look all the way over here in the red box, those are head and neck tumors. And the signature was more elevated in head and neck than any other tumor type, really suggesting that this is a common problem here. And the reason that this is important, there are probably many reasons this is important, but hypoxia signaling in head and neck tumors and other tumors has been associated with defective apoptosis, invasion and metastasis, epithelial to mesenchymal transition, resistance to cancer therapies, and elevated rates of mutation. So really a smorgasbord of potential negative consequences. And all of this was important enough that a couple of years ago, Bill Kalin won the Nobel Prize for working out the canonical mechanism for how hypoxia signaling is regulated in tumors, right? Characterizing the role of the VHL protein in mediating HIF, the transcription factor HIF-1A and also HIF-2A, the destruction, proteolytic destruction, and in the absence of VHL, how this leads to constitutive signaling.
But how do we actually know that a tumor is hypoxic? And I've listed kind of 3 ways up here that we might determine that hypoxia is present in a tumor. And I'll make the point that the first one on the left, which is the use of PO2 electrodes, the actual tissue measurement of hypoxia, is actually a very rare thing to do. We don't generally have those measurements available to us. More commonly, we'll use surrogates of hypoxia, so gene expression profiles. I've already shown you one of those, or immunohistochemical staining for downstream markers, so CA9 or other proteins that are generally upregulated in the setting of hypoxia. And we'll kind of come back to this point a little bit later in the talk. But we think that this is important. This is a very old study. It's a study in mice, actually, in which radiation was given under conditions of hypoxia versus normoxia versus high oxygen exposure. And then radiation was given to tumors. And what you can see is under high oxygen tension, the tumors die, or the tumors decrease at much lower doses of radiation. In contrast, under hypoxic conditions, the tumors survive more significantly than they do under normoxic conditions, right? So really suggesting that this can lead to radiation resistance. Specifically within head and neck tumors, this has been studied by several groups, and this study was in 274 patients in which hypoxia signaling was assessed by IHC expression of HIF-1A. Across all patients, it did look like it was patients with high HIF-1A expression did significantly worse in terms of their overall survival compared to patients with lower HIF-1A expression. And this was particularly prominent in this study in the HPV-positive tumors. But this has also been looked at pretty significantly in HPV-negative tumors. So this is a different approach to measuring hypoxia. In this case, it's a gene signature panel, 26 gene panel, 194 patients. Patients with high levels of gene expression on this panel did significantly worse again than patients with low expression. So hypoxia signaling again being a negative prognostic marker here, and this held true very apparently in HPV negative population. So really, in both groups, you get this effect. And people have thought of targeting hypoxia in several different ways. Everything from, at the bottom, inhalation of modified oxygen content, so hyperbaric oxygen has been considered, carbogen, kind of modified molecules, hypoxia activating drugs. Dr. Bhatia mentioned some of the angiogenesis inhibitors and ongoing work there, really targeting the downstream consequences of hypoxia, right, leading to VEGF signaling and further immunosuppression and other effects. And also drugs that target hypoxia, that target HIF directly. And I'll talk a little bit more about some work that we're excited about with some of these drugs. But none of these has led to a slam dunk yet. None of these approaches has been a clear winner, I would say, thus far. And this sort of got us thinking a little bit. This is the traditional pathway I showed you before with VHL mediated destruction of HIF-1A under hypoxic conditions, low oxygen tension conditions. But actually, it turns out that there are other ways of driving hypoxia signaling. And so there are oxygen-independent mechanisms to drive HIF-1A expression. This has been best studied in immune cells, like myeloid cells, in which TLR activation, toll-like receptor, innate sensing of bacteria or other things can actually drive NF-kappa B signaling and associated HIF-1A expression. This has also been studied in the setting of inflammation, in which STAT3 and HIF-1A can somewhat reinforce each other's signaling. And the way we became interested in this was actually looking at tumor cell lines. So we looked at expression profiling within the Cancer Cell Line Encyclopedia, which is more than 1,400 tumor cell lines, where we have kind of multi-omic profiling and can learn a lot about the gene expression patterns, the mutational profiles of the tumor cells. But importantly, in which these tumor cells were cultured under normoxic conditions. So there is not low oxygen tension present, it's cell culture. And what we found is that you actually see differences in hypoxia signaling at baseline in these tumor cells. And the very highest is kidney cancer, but kidney cancer is known to have genetic alterations in the VHL protein that leads to constitutive hypoxia sensing. And right after kidney cancer, you have head and neck cells again. And so we were very interested in this idea that you're getting hypoxia signaling under normoxic conditions. And so we looked, and this project is led by Alex Fry, a talented surgical resident in the lab. We looked to see whether this is true directly in some of these tumor cell lines. And sure enough, we saw that you have increased expression of HIF1A in a number of head and neck tumor cell lines, and in this case, both HPV positive and HPV negative, certainly compared to this sort of melanoma cell line on the left, but also even more dramatically compared to some of the other non-tumor cell lines. And because we're thinking about inflammatory drivers of this process, we also looked at STAT3 signaling. And here, head and neck tumor cell lines had higher STAT3 signaling than any other cancer type. And again, you could see this maybe not quite as clearly in some of the cell lines, but certainly clearly in some of them, that you had elevated phospho-STAT3 signaling. Again, constitutive and at baseline, driven by the tumor cells in a cell-autonomous manner. So this made us step back yet further and sort of ask, okay, well, if we think there may be an inflammatory process going on here, and the model is that this is driving both hypoxia signaling and STAT3 signaling, do we see any inflammatory mediators that are elevated in these tumor cell lines, right? That's what you would predict if you have cell-autonomous inflammatory sensing. And so we performed a cytokine beat array of these same tumor cell lines. And again, we saw that you see a fairly striking upregulation of IL-6 and IL-8. These are, STAT3 associated and are capable of driving STAT3 and responding to NF-kappa B activation cytokines. You also see, at least in the FADU and to some extent in the Cal27 HPV negative tumor cell lines, some upregulation of VEGF as well. And so then we're starting to get very interested, given that we studied tumor microenvironment inflammation in the immune system, and started, reviewing some of the data that suggested that IL-6 is another negative prognostic marker in head and neck cancers, right? Higher IL-6 levels have predicted a worse outcome for patients. This is IHC staining of about 140, 150 patients. And the reasons for this are possibly manifold, but effects of IL-6 can include effects on angiogenesis and fibroblasts, survival and proliferation of tumor cells, an MDSC and M2-like macrophage polarization, as well as decreased T cell function. IL-8 is equally interesting. IL-8 has independently been validated as a predictor of poor response to immunotherapy in a number of tumor types, including in work performed by Kurt Schalper here at Yale. Really with the model being that you're attracting in tumor-associated neutrophils and suppressive populations similar to the IL-6. And so this is all, this was all starting to gel for us a little bit. I don't think we're all the way there. But we said, okay, this is true in tumor cell lines. And, if true, it has implications for the immune system. Is it true in patient samples? And so we looked at patient samples collected in the Cancer Genome Atlas, and we looked for expression signatures of NF-kappa B inflammation, STAT3, and hypoxia, and asked whether these were correlated with one another, with the prediction being that the tumors in which you get these pathways triggered, they'll all be triggered together. And you see quite a tight correlation within the tumors collected in the Cancer Genome Atlas between hypoxia and NF-kappa B, between STAT3 and hypoxia, and between STAT3 and NF-kappa B. We asked whether we could detect any untoward effects on the immune system associated with these states. And in this case, we compared gene signatures for high hypoxia versus low. It was the top 25% of hypoxia gene signatures versus low when we assigned gene signature scores for each patient sample. And what we saw were significantly decreased CD8 T cells in the hypoxic tumors, significantly increased cancer-associated fibroblasts, and significantly increased macrophage populations, all really supporting the idea that this signaling network, which is associated with immunosuppression. And so if you start to put this together into a model, the way we think about it is kind of starting with the HIF and NF-kappa B activation. We know these cytokines appear to be present. We know HIF is stabilized, and we know that we're getting some STAT3 signaling as well. We think that in tumor cells, the STAT3 signaling is associated with survival, growth, and potentially EMT. We think that these cytokines are likely to lead to immune dysfunction through the attraction of MDSC and tumor-associated neutrophils. And really, where we're at now is we're thinking a lot about, okay, what is driving these pathways? What's upstream? So being immunologists, we're thinking about damage-associated molecular patterns and pathogen-associated molecular patterns and how these things are sensed by the immune system. And what seems like it must be true is that this innate sensing is happening through the tumor cells themselves. They're driving their own kind of inflammatory network. And so we have a number of ideas about this, but I actually wanted to wrap up by talking a little bit about whether we can intervene and whether we could, think about strategies that could eventually be applied to relieve these states and improve outcomes for patients. And so our first attempt at this was not very successful. We went back to our cell lines and we said, let's try EGFR inhibition. Let's see if that, there's been some reports that interacts with STAT3 signaling. Let's see what happens there. And what you see is you start out with some pSTAT3 staining in Cal-27 and FADU, but you actually get more with EGFR blockade with cetuximab. And we spent a long time puzzling over this. And I can't show you data here tonight, partially because we're not done with the studies, but our best hypothesis is actually that we think that this inflammatory network may be driven by cell stress and by cell death, and that by actually having some anti-tumor effect with cetuximab, we may have actually increased this signaling with the EGFR inhibition. We didn't see much of an effect at all with VEGF blockade here. However, we did have better luck in terms of pSTAT3, somewhat using a STAT3 inhibitor, which was okay, but not amazing. We didn't really stick with it. But particularly with HIF-1A inhibition. This is a kinomycin, a drug that's been studied in cancer, but I don't think extremely extensively in head and neck tumors. And this seemed to turn the pSTAT3 signaling. And so, we've gone forward with further studies of kinomycin, both in mouse models and in cell models, and we're pretty optimistic about how that's looking. We've also started to think, because NF-kappa B is activated, what could be upstream, what could be driving this? And we've hypothesized that activation of toll-like receptors, sort of like in the figure I showed earlier, may be at play here. And so we've tried, in addition to kinomycin, MyD88 inhibition. MyD88 is a key signaling mediator downstream of toll-like receptor signaling. And so this graph is actually showing IL-6 production, either, this is our melanoma cell negative at baseline, but you can induce IL-6 if you use poly-IC stimulation. This is our HPV positive cell line, and then on the right are HPV negative cell lines. And you can see the MyD88 inhibitor in purple and kinomycin both appear to significantly decrease IL-6 production in the HPV negative cell lines specifically, compared with your unstimulated control. And so, we're thinking that these could be strategies that could be carried forward, and hoping to prove that out over the next kind of several months. So in summary, I hope that I've showed you that hypoxia signaling is common in head and neck cancers, and that it correlates at least with innate immune activation and also with immune evasion in patient samples. That head and neck tumor cell lines appear to demonstrate cell-autonomous STAT3 and HIF signaling under normoxic conditions. That head and neck cell lines constitutively produce immunosuppressive mediators, and that STAT3 signaling and mediator production could be reversed by targeting HIF-1A and MyD88. What are the clinical implications here? Where are we hoping to go? So our hope is that targeting HIF signaling rather than actual hypoxia or even angiogenesis may be a strategy that could improve clinical efficacy. Specifically, we're thinking that targeting this innate immune signaling network could improve immunosuppression, could lead to combinations with PD-1 blockade, or could directly target tumor cells. And that actually these types of strategies could be combined with the type of clinical studies that Dr. Bhatia presented. If you add on HIF inhibition that you may be able to get a better response. We think that biomarker-driven approaches are possible in this setting. Particularly, I think our evidence has been better in the HPV-negative tumors that this could be a valuable approach. And I think given some of the approaches I've shown above, you can imagine using downstream markers of hypoxia like CA9 or gene signatures, or even peripheral cytokines in order to perform patient selection for the patients who would most benefit from these types of therapies. I think with that, I will wrap up and just wanted to thank the members of my lab, as well as collaborators, mentors, and funding, and certainly Dr. Burgess and all of you for the chance to present tonight. Thanks.
Thank you so much. Fascinating and really novel work in this field. I don't know if there are any questions in the chat, but as I was listening to you and then reflecting on what Aarti Bhatia had been talking about with the the idea of semaphorin 4D targeting, we've seen in the radiation oncology world an interest in using nuclear medicine imaging for hypoxia with FMISO as a predictor of responsiveness to radiation therapy. There's a series of trials that have been done at Memorial where they use baseline normoxia as determined on an FMISO scan to decide who's a good candidate for treatment deintensification or not. But I'm wondering if it would be fruitful for us as we start to introduce drugs that target the tumor microenvironment to be thinking about stratifying patients by hypoxia. And you showed us a lot of ways to use gene signature or IHC. I think in a dynamic way you could think about doing FMISO, but we've just sort of assumed you measure whether or not the target is there, and it's going to be the same implication on the tumor microenvironment for everybody who expresses it. And maybe I think what you've been trying to show us is that that's not necessarily going to be true.
Yeah, so I think that, so several great points packed in there. I think that one thing that's probably important is to try to establish the context of that hypoxia signaling. So, establishing some of the other immune features of the tumor or cell types could help. And then this idea of dynamic monitoring, I think, is extremely interesting in that, it may be that some of the inflammation that a lot of these inflammatory pathways are connected. And you may not want to shut off all NF-kappa B signaling all of the time. This may be something that you want to inhibit, get rid of your suppressive cells, and then, reactivate. And so you can imagine actually sequencing therapies in a way that would be useful. And then the ability to do some form of dynamic monitoring would be incredibly helpful in that setting.
Yeah, terrific. Maybe we should think about trying to do that. Any other questions? Either use the Q&A or the chat. If not, thank you very much. That was fabulous. And now I'm really happy to be introducing our colleague Navid Hafez from the Phase 1 team. So he's a graduate of the University of Wisconsin-Madison School of Medicine. And then we're really, really proud that he's also a graduate of the Yale Residency and Fellowship. And he's a assistant professor in the section of medical oncology, very active in early phase clinical trials, also a member of the developmental therapeutics program, a core faculty member for the hematology oncology fellowship program, and a recipient of the Robert Wynn Career Development Award for an early stage investigator to support work to increase diversity in clinical trials and transform the clinical research landscape. In addition to early phase clinical trials, he's also got an interest in immune-related adverse events, which are extremely prevalent in medical oncology now, and chairs our immunotoxicity tumor board, where in concert with colleagues from allergy and immunology, they review complicated and severe immune-related adverse events related to immune checkpoint inhibition. So he's going to be talking to us about novel targets in phase 1 trials, and really delighted to have you here, Navid.
Thank you so much, Dr. Burness. And thanks to Dr. Bhatia and Dr. Ishizuka, they kind of set me up for this as well. I don't have data really to present like they did. And so really, I thought we would just kind of look, because in phase 1, right, we're essentially, at least we don't have much clinical data to look at. I thought I'd kind of share what we have in our portfolio and in the pipeline that is kind of relevant to head and neck cancers. Can you guys see? Does it appear right on the screen when I share?
Yeah.
Okay, yeah. Sure. The one thing I'll mention before we get started looking at kind of specific novel targets is just I like to always give a reminder about phase 1 in general, and how really developmental therapeutics and early drug evaluation is evolving kind of rapidly for us over these last few years even. Phase 1 is no longer just a place for the, completely refractory stage 4 patient who's tried every, therapy of known benefit, or, every approved therapy. That is, less and less and less written into protocols, and certainly into practice in terms of how trials are kind of opened and approved by the FDA, and how we accrue to them, and the populations we're looking at. These are increasingly biomarker driven trials, are not just these kind of all-comer, any solid tumor malignancy. We are investigating in earlier lines. They're not all, again, refractory patients I'm alluding to. We even have drugs in our portfolio that are looking into the first line. Treatment naive patients, they will allow on some of them if they're appropriately biomarker selected. Some of our trials allow untreated brain mets now, because we have drugs that we think have seen a CNS activity. And really that part of what we'll talk about today, and looking at what we have in our portfolio that's relevant to head and neck, is that phase 1 is no longer really just kind of dose escalation, looking at toxicity and determining a maximum tolerated dose. These are essentially all phase 2 trials now. Phase 2 trials have been engulfed by phase 1, and there's a lot of disease specific cohorts. There's a lot of combinations. There's a lot of really complicated correlatives being studied as well on these trials, and so just a little kind of reminder about what we have. And, I think because of that, I really like to emphasize to just, send patients, or at least reach out. If you don't send a patient, but just reach out if you have a patient that you're curious about, if we have anything in our portfolio, reach out before they need us, because we might be able to add to their, their list of options for their, next potential therapy. We have a lot of targets in our portfolio in the phase 1 group at Yale now. Not all these are relevant to head and neck, but they're evolving. That's the point to make about this. If I showed you this, a month ago, it would look different, and a month from now, this will look different as well. Some of the things to highlight for us, and I'm going to start with a disclaimer and really an apology. Head and neck cancers are not a strong suit of our portfolio here, and partly it's because we have such a great head and neck team at Yale already, right? So Dr. Burness, Dr. Bhatia, they already have really great clinical trials and really great studies in their portfolio, and their patients don't often need a home in phase 1, so it's not the strongest space for us in terms of novel targets or therapies. And really, when we think about the big players, the big kind of mutations or the signatures that we see in a lot of our head and neck cancers, and certainly in the squames, P53, CDKN2A, PTEN, PI3 kinase, we have actually nothing in our portfolio at the moment that would be kind of biomarker driven study for these very common mutations. In the past, we have had drugs targeting CDKN2A, and I highlighted PIK3CH because literally, if we talk a week and a half ago, we had something, and I was going to talk about it. It was related to Notch1 mutation as well. We had a PI3 kinase inhibitor from Haihe, which is a Chinese company. Unfortunately, literally just right before Halloween, we had to shut that. They shut down all U.S. sites, and they're no longer distributing drug to the U.S. So again, just the point that this is evolving all the time, and what we're talking about today may look different in a couple of weeks. I will kind of continue the theme that Dr. Bhatia and Dr. Ishizuka talked about, looking at novel targets in immune oncology. So looking at alternative checkpoints or co-stimulatory molecules in specific and kind of related, where we're looking to accrue in head and neck cancer. I wanted to talk about this Notch1, which we'll kind of skip over a little bit, but we do have a couple other agents that are relevant, I think, to head and neck cancers, looking at FBXW7 mutations and looking at pro-apoptotic agents. And then we just opened, just this last week, IIT, Dr. LaRusso's IIT, looking at BET and HDAC inhibition. And then if we have time, I thought maybe we could talk about DNA repair and how that may or may not be important in our head and neck spleens. So we have several immunotherapy trials that are specifically looking for head and neck patients, and I'm going to just kind of go over these one by one for you. So we have an IL-15 fusion protein from Roche, XmAb24306, and this is, like I said, it's basically an IL-15 plus the IL-15 receptor. So you know, cells may have knocked down their own receptor, but the idea is this will kind of stimulate and cause proliferation of our immune cells, both the T cell response and the natural killer cell response, which is going to be a theme of a lot of our agents here, is looking kind of beyond the T cell and looking for non-antigen presenting, you know, or non-neoantigen requiring, you know, immune cell for attack. And this is a trial that is being looking at this agent as monotherapy and in combination, and it has a dose escalation that is concurrent as a monotherapy and as a combination. And we're looking at several different kind of schedules for both the monotherapy and the combination. The important thing here is if a patient would start monotherapy, they are allowed to cross over to combination therapy. We are now in, and I kind of wrote some notes to myself to remind myself exactly where we are on some of these dose levels. But we are actively accruing on this escalation at this time. We have a PTPN2 inhibitor from Calico Life Sciences, and now they've partnered with AbbVie to help further the development. So PTPN2 is the gene that encodes for protein tyrosine kinase that's expressed on T cells. And this, as you might imagine, with this tyrosine kinase, it modulates a whole variety of kind of physiological functions. And since this particular one is expressed on the T cell, these are all, you know, related to kind of T cell survival, progression, proliferation. And this is a drug that is an active escalation in our combination. Now we've actually escalated above this kind of dose escalation schema here because it's been very well tolerated so far. So we're up to, in the combination now, a 4th dose level essentially. And it is accruing, you know, multiple malignancies, including head and neck cancers right now. And if we see signal in that group, then the potential is that they would add a specific cohort just for our head and neck spleens. We have a study of a TREM1 agonist from Pioneer Therapeutics. TREM1 is expressed on a number of kind of myeloid cells in the tumor microenvironment that we think are immunosuppressive. This kind of converts them to a more active and non-suppressed form. And this trial as well, I'm trying to pull up where we are. So we are in combination on this trial as well, up to this level here. I don't know if you see my marker or not. We are on a 3 milligram combination. Once, and this is accruing head and neck squamous. Once we do determine the kind of, either maximum tolerated dose or at least come up with a recommended combination dose, there already is a planned expansion specifically for head and neck cancers in combination with pembrolizumab. We have a probiotic agent from Genome, South Korean company, that is trying to re-stimulate or change the gut flora to help stimulate immune responses in patients. They're looking in the immune refractory population, actually, this is being tested strictly in combination with atezolizumab, and they are very interested in head and neck squamous. A drug from Tizona, TTX-080. It's an HLA-G antagonist, which blocks engagement with ILT2 and ILT4. We'll come back to those in a second because we have another drug that we'll talk about. And essentially what this does is it's an inhibitory receptor basically on a variety of immune cells. And so it's another immune checkpoint, and we're blocking that checkpoint. And the idea is hopefully we can help with other cells, again, not just T cells, looking at natural killer cells and other dendritic cells as well. We have two arms looking at the refractory head and neck population, pre-treated IO population head and neck. One in combination with pembro and one in combination with cetuximab. And these are actively accruing on these expansion arms at the moment. We have an anti-CD277 or BTN3A compound from Imcheck Therapeutics. This is the one where we do have a few weeks ago now some clinical data to talk about and to present. We just presented this data at ESMO last month in Paris. This is a negative co-stimulatory molecule that's on both tumor and stromal cells. And what this drug does is it basically sensitizes those tumor cells to T cell killing. So it's specifically activating the gamma-9 delta 2 T cells. And this is being investigated in monotherapy in combination. We are through escalation, actually, and this was actually the expansion cohort that was presented. It was a solid tumor cohort, combination cohort, and have 40 patients. They were accruing head and neck. Unfortunately, they only had one patient with head and neck cancer out of the 40, which is very hard to see on our graph here. But they had stable disease at first assessment and then ended up coming off around 13, 14 weeks with progressive disease. But they're very interested, so they have opened a new cohort. So we just opened a new cohort that is specific to head and neck cancers, cohort E. So we are interested in accruing, and that is an option for patients. From Treadwell, we have an HPK1 inhibitor, and this inhibits HPK1 mediated signaling pathways and proliferation of those cells, and it's the same thing we're kind of looking at the whole time. So this is looking at effector T cells, and kind of just doing the general downregulating the T cell activity, therefore downregulating the cytokines. And this is an immune checkpoint again, so inhibitor again. So we're getting rid of the downregulator. Here we are into, this is a kind of a stupid schema because it doesn't give us a whole lot of information on this schema. We've gone several dose levels up, and so far very well tolerated. We're at the 540 milligram as monotherapy, and we are at 160 milligrams in combination with pembro. There are concurrent dose escalations going on right now. We also recently opened, we've had a few personalized cancer vaccines in the portfolio, all of which have been interested in head and neck cancers. This is a new one from Nykode Therapeutics and Roche. And this has we already have 2 doses that are being evaluated concurrently. patients get an induction of a personalized neoantigen vaccine that is built from a tumor sample of their own. They do need a fresh biopsy for that. And then after this induction period, where they get it in combination with the TZO Q3 weeks, then they move to like a Q12 week vaccine booster, essentially, while they continue a TZO. This is a bit of a challenge, and it requires a patient that you think is going to be fit enough to participate, because they're quoting, I don't know if you can even see this schema, it's really poorly copied, but 10 to 14 weeks. We're actually right now, because of supply chain issues and all the same things that make everything expensive now, we're quoting 22 weeks manufactured. So this basically takes half a year to manufacture this vaccine. Patients are allowed to have any number of interval therapies, which can be chemotherapy or other immunotherapies, are allowed per the protocol in between. And it's essentially expected that patients will be getting interval therapy. But if you have a patient, again, early in their course, it's an interesting area to look. From Biond, again, we have this ILT2 antibody. This is the leukocyte immunoglobulin-like receptor member. It has many aliases, and this is another immune checkpoint as well. It's the PD-1 to our TREM1 PDL1, essentially. It's the partner, and it's being tested in monotherapy and in combination. And we just opened a new. So this is all. I thought we had a specific head and neck cohort, but I'm thinking of another trial. So this is looking in it's just in everything, and all these diseases we see here. So they're kind of several classic IO sensitive agents, but also looking in biliary tract and colorectal cancers as well. And we're open right now in combo and in the monotherapy escalation. Pivoting a little away from immunotherapies and looking at our other options and other novel targets. So Dr. Pal-LaRusso just opened NCI 10499, which is a study of the BET inhibitor Zen 003694 and the HDAC inhibitor Entinostat. So these are really both epigenetic modifiers, and we do know BET inhibitors are quite active in a sense in a variety of solid tumors for various reasons. One, they inhibit expression of kind of important proliferative pathways, including particularly MYC and BCL2. They also inhibit apoptosis. And this is BET, the bromodomain kind of proteins in general. They also regulate cell cycle progression, and so we've seen historically in studies a lot of activity from these drugs, but they're plagued by toxicity. Essentially, has been the main issue in development of BET inhibitors. HDAC inhibitors, of course, are crucial in many of our hematologic malignancies, but are not particularly active in any way by themselves in solid tumors. But the idea here is that because of the synergy, we can actually get away with much lower doses of BET inhibition when we combine with HDAC inhibition. And there's really interesting kind of preclinical data, and we've actually seen good clinical data in certain types of malignancies that are relevant to our head and neck group, right? So in particularly in the nut midline carcinomas, which have a bromodomain 4 fusion, which we know it's very, very active to inhibit BET in that population. But also in our adenoid cystics is where there's really compelling preclinical data too. And so those are really two populations, obviously much more rare. We're not, but if people on this call or anywhere, if folks that have those, this would be a really interesting option for them to consider. This is just what the schema looks like. It's a little bit of a tough study. Patients need 3 biopsies. They do a baseline pretreatment biopsy. They do a biopsy after the run-in of BET inhibition, and then they do another biopsy when they're on the combination with HDAC. And this is kind of the phase 1 dose escalation schema I'm showing. The phase 2 component is really just an expansion across all solid tumors once we have an acceptable dose limit. The schema and the treatment plan looks exactly the same. There's a run-in, a biopsy, and then a combo with another biopsy. I mentioned kind of looking at other targets and tumor suppressors in head and neck cancers. So we don't have, again, a whole lot in our portfolio, but we have an FBXW7 targeted drug, essentially. So this is ubiquitin ligase. It acts as a tumor suppressor, degrades, marks, multiple other important proteins, basically, for ubiquination. And, one leads to sensitivity to other drugs, and particularly the one I want to focus on is PKMYT1 inhibition, and that's the main regulator of CDK1. So this mutation is not super common, but but relevant and prevalent in head and neck squames. It's between, I'd say, some of the data even have 15%, but somewhere around probably 10% of head and neck squames will have this mutation. And we have the MYTHIC study right now open at Yale, which is testing this PKMYT1 inhibitor from Repair, and that study is open. I'm going to talk about that in a second when we look at our DNA Repair portfolio as well. And then I think I just trying to grasp for straws a little bit and looking at the ways we can help, targeting apoptosis, right? Given that this is such an important and commonly affected pathway in head and neck squames, right? So p53 mutations obviously are extraordinarily common. We see them in 70% of the HPV negative head and neck squames, and then obviously the HPV positive ones, although they may have a wild type p53, we know that that's being knocked down and inhibited as well as RB1 by the virus itself. So this kind of inactivation or mutation of p53 obviously is hugely important, and has been an incredible challenge to target with a drug. But other methods, the non-p53 triggered methods of apoptosis can still, I think, be utilized and acted on, and that's part of what is being looked at now by IgM Therapeutics. They have a DR5, a death receptor 5 or trail agonist antibody that is looking to literally triggers kind of a caspase mediated apoptosis with that drug, and it's being evaluated in monotherapy and in combination with birinapant, which is a small molecule inhibitor of apoptosis inhibitor, an IAP inhibitor. This is a kind of what the schema looks like. They are not planning at this moment a dose expansion in head and neck, but if we see activity they are accepting head and neck cancer patients, and if we see activity in the dose escalations, both the mono and the combos, then that is a potential that they would open up a head and neck cohort in expansion. The DNA repair I brought up, I thought we could talk about, because it's not traditionally a space that I think, and maybe, Dr. Burton, Dr. Bhatia, you can help fill in for me here, that we think about in head and neck cancers, but we know it's an area that is often actually mutated. I don't think there's big key mutations in DNA repair proteins, but all comers, it's probably somewhere around half of head and neck, especially squames, seem to have some mutation in a relevant DNA repair protein. This was presented at ASCO last year, where the group, Bircher was the author, presented. They looked at 170 patients, both tumor and circulating tumor profiles from Foundation and from Guardant, and they found, they looked at a panel of 16, homologous recombination proteins and looked for mutations in those. And they found that 50% of the patients had that. So it's an area that is kind of, we're looking at. We don't know how clinically relevant all that is really in many solid tumors, but certainly interested in looking in head and neck as well as other places. And we have, I'd say it's a big focus of our group in phase 1 here, largely because for probably various reasons, we've kind of been grandfathered into it. We have great science here from people like Peter Glaser and Ranjit Bindra, and Megan King, who are really have power labs that are looking at DNA repair pathways. And out of that has come, a lot of IITs in this space, as well as kind of relationships with sponsors that have drugs targeting, targeting various proteins in these pathways. So I'll focus on ATR inhibition because we have several drugs in our portfolio that do that. We have a drug from Bayer that unfortunately at this moment is not recruiting in head and neck. We have my IIT through NCI looking at AZ's ATR inhibitor, Saral, in IDH mutant solid tumors, which are very rare, unfortunately, in head and neck cancers. But if we see them, it's something to think about. And then we have this combination trial from Repair. They make an ATR inhibitor, this is RP3500, and they also make that PKMYT1 inhibitor that I was talking about. This is the MYTHIC study. And this is, again, so that although FBXW7 is not a DNA repair protein, it's an opportunity that patients could get on that trial easily. This is just some data about that drug. We know it has monotherapy activity in patients who have underlying DNA repair mutations. And I just wanted to point out the studies that we have. So we have the ATTACK study. If you do find these mutations in our head and neck patients, they're allowed to just jump onto this, and this is given in combination with PARP inhibition. Patients can either be selected to olaparib or niraparib. And then we have the MYTHIC study that I was talking about, which is really the study that's evaluating RP6306, which is the PKMYT1 inhibitor. But it is being developed and investigated both as monotherapy and in combination with their ATR inhibitor as well. And that is my story. Thank you everyone for your attention this late too. I kind of wanted to ask my own question, if I'll jump in, which is, we talked a lot about the role of hypoxia in the immune kind of response and the immune, both microenvironment and the deliverability that kind of effector cells as well. But one area of interest, I guess, to us, and Joseph Kim was actually looking at this with his IIT, was looking at how hypoxia affects our DNA damage response. And I don't know, Jeff, if you have insights into that or thoughts about that. What the work that Peter Glaser had done had shown that how hypoxia can inactivate BRCA. So independent of mutational status, you have wild type BRCA, but functionally the tumor still has a BRCA-ness, and then therefore that might make us susceptible, or make that tumor susceptible to PARP inhibition or other DNA damage targeting drugs. I know, and again, Dr. Burns, Dr. Bhatia, I'd be interested in your thoughts on this in terms of, we have the mutations that we talked about that seem to occur in head and neck cancers, but also, I know ATM silencing is a thing. So we don't see ATM mutations frequently in head and neck cancers, but whether it's hypoxia that's silencing it, I don't know the data. So what is silencing it, but there might be a susceptibility in that space to exploit with drugs like ATR inhibitors and other.
So that's a super interesting idea. We had previously looked a little bit at, so I showed some data from the Cancer Cell Line Encyclopedia. One of the big experiments that's been done there is to knock out all of the genes in the genome and look for differential susceptibility. And something you can do, and in fact we have done, is look at high hypoxia signaling versus low hypoxia signaling and look for differential vulnerability to the loss of any given gene. And so it'd be pretty easy to go back and look in that data and see, do you see ATM, do you see some of these targets coming up as differentially susceptibilities with hypoxia signaling there? Yeah, we should talk after this.
I think there's also a lot of interest in emerging evidence that drug target affinity can be different in hypoxic conditions. And in fact, P53 conformation is different in hypoxic conditions or low pH conditions than it is maybe in some of our lab models. And so one of the projects on our spore collaborates with Erica Galemis at Fox Chase, and she has the ability to do cell viability experiments of novel synthetic lethal combinations in different, like normoxic, and then different degrees of hypoxic conditions to kind of look for some of these differential effects. So I think hypoxia is actually one of the great ignored vulnerabilities in head and neck cancer, because as Jeff showed, it's like massively different in this cancer than in many other cancers. And then on top of that, we like cut into it, tie off a bunch of blood vessels, radiate what's left, you know. So by the time patients have recurred, the degree of hypoxia is maybe even much more dramatic than what these preclinical models show. So I think in terms of DNA damage repair, and in terms of immunosuppression, in terms of just understanding what it does to the structure of our targets and our drugs and their binding affinity, completely understudied. I just wanted to, you were a little apologetic about raising DNA damage. I think it's enormously important. First of all, we have some BRCA. We have a lot of FANG pathway mutations apart from BRCA. And then we have the hypoxia-induced BRCA-ness, as you alluded to. I wanted to ask you if you know anything about this drug CYT-0851, which is a RAD51 targeting agent, because we have been sort of hearing that they're seeing monotherapy responses in HPV positive.
I don't know much. I don't know much about it. I've heard of it, but we have a small molecule meeting that we hear about stuff kind of in the pipeline. But I do not. I've only heard that it exists. I don't know much about it. It does remind me that another agent that would have been interesting to talk about is we have a Cybrexa drug, CBX12, and so this is looking specifically at low pH environments. So it's a pH low insertion peptide. Basically, it's almost like an ADC, but instead of an antibody, it's this pH low insertion peptide is the delivery mechanism, and then the payload is exatecan. So it's thinking we're like the idea is this is going to be like a new Enhertu or something, except instead of
invented here at Yale by Don.
Invented here at Yale, exactly. By Dr. Bindra, I guess, and his team, and so
Don Engelman, I think, first developed the flip concept.
Right. Oh, sorry. Yeah, exactly. The science, and then this particular drug is Ranjit's extension of that. Sorry. Yeah. So that's that. Unfortunately, at the moment, is not looking at head and neck, but it seems like would be a great place to investigate, and maybe since they are right here down the hall.
Yeah. We should think about that.
We can ask them to start looking in that space. Yeah.
So, Navid, could I ask you just to throw into the chat the information about how people get in touch with you? So, if there are people on, the call who saw something in your menu that they think is appropriate for a foundation panel they just looked at this week, how do they track you down?
So, and it's a great question, and there is now apparently a phase 1 consult in Epic, which has been very hard to find. And that's certainly one way to do it. We like personal reach outs because we can help, the referring doc or whoever just kind of look and see, do we have something that makes sense in our portfolio? You can do a quick glance. Do we have something for these lines or this kind of clinically relevant space for you? And then if that makes sense, then we can formally kind of do a consult and have a patient come in. So, I'm dropping my email and number is literally probably the best way. Ultimately may not be the most efficient. It'd be great if we had a better way to do it, but that's kind of how we're still doing it right now, is just reach out to me. And happy to discuss a case or look over a case and tell you where we're at. All of these trials I mentioned are open and active at this time, and are literally actively accruing head and neck patients. The issue, though, sometimes with, as I alluded to, so a couple of those were in kind of expansion now, which means we have a fair number of slots, and so a patient come in. But some of those were in this kind of concurrent dose escalation space, which is a very tricky space to get patients on trials. We have to, essentially 3+3 design. So we're looking at 3 patients at a time, and then you're waiting and monitoring those patients for a month before your next group of 3 patients will be enrolled. And so depending on when, you may reach out about a patient, we may at the moment not have a slot. We'll have a trial, but not a slot for them, and may have to wait. Another reason why we always say, get in touch with us a little sooner before you think they need that next line, so that we can try to plan ahead with you to find a home and have them ready then for when we anticipate a cohort opening.
Well, this has been fantastic. I mean, just such a wealth of information. Thank you. So, Saral, I'll turn it back over to you.
Yeah, so thank you, everybody, for joining us and staying on. We're going right to the hour. It's perfect timing, actually. So this does conclude our 3-part series, CME series. All sessions will be available at the Yale Cancer Center website, and the links will be via social media as well. I hope you all learned something. I do see the names of some guests here who've been on all 3, actually, which is great. Thank you all. And I guess we'll end there. Have a good evening, and hopefully we do this again next year. Thank you all so much.
Good night, everybody.